So thank you again for making it all the way through the day. I've been also asked by our leader, Alicia, to make one other announcement, and that is that we're sensitive to the fact that we're running a little bit over time. So if you have another obligation, or like our medical students, if you just feel like your brain is full for now, feel free to leave. We are recording all the sessions, so they will be available to you unedited in their full form at a later time if you wish to go. But again, thank you for the chance to be with you this afternoon. I notice nobody's leaving. Most of the medical students, when they get a chance to opt out of a neuro-ophthalmology lecture, they're like out the door. So you guys are very brave. So, sorry? Oh, okay, yeah. So what I wanted to talk about today was just to talk a little bit about some of the causes of eye symptoms in myasthenia gravis. Many of you who are either patients or caregivers are probably very familiar with this because, as we know, about 80% of patients with myasthenia gravis will have ocular symptoms as their first manifestation, and I've not met a patient with myasthenia that hasn't had eye symptoms at some point during their course of myasthenia. So obviously it's very common, but I wanted to talk just a little bit about how we think about the disease process and how it affects the eye and affects vision. And then what I thought might be interesting, again, just to kind of keep within the spirit of advocacy that many of the other speakers have talked about today, is to talk about what eye symptoms are commonly associated with myasthenia and which ones are not. And the reason why I think this is important is that vision is obviously a very complex neurologic process, but it's also a very unique subjective experience. And I think that many providers, optometrists, ophthalmologists, primary care providers, even some neurologists, if you're not used to thinking about myasthenia gravis or any other chronic neurologic condition, it's very easy to group every symptom within the umbrella of that condition. So if you have myasthenia, if you have multiple sclerosis, if you have Parkinson's disease, it can become very easy for many people who are listening to your symptoms to kind of group everything under that umbrella. And sometimes that doesn't get to the root of the problem. And so I just wanted to spend some time talking about how we think through these things in myasthenia and differentiate those things that may be myasthenia related and some things that may not be. So here is the requisite epidemiology slide. You've heard these numbers earlier today, but I wanted to just share a little bit about how it pertains to ocular myasthenia gravis. Of course, pretty rare, about 10 cases per 100,000 in population. We see a sex and age dependent distribution, so women tend to be affected in their 20s and 30s, men a little bit older. Thymoma we find in about 15% of adult patients with ocular myasthenia gravis, so not a high number, but certainly something that we want to look for. And as Lisa pointed out earlier today, we do see an association of myasthenia with other autoimmune conditions. So rheumatoid arthritis is the example that Lisa shared with us earlier. Another common overlap that I see in my practice is with thyroid disease. So there's a condition called thyroid orbitopathy or thyroid eye disease, which is another antibody-mediated condition that preferentially affects the muscles around the eyes. And I have several patients who have concomitant ocular myasthenia and thyroid eye disease. So they can do some of the same things. Thyroid eye disease affects the extraocular muscles. It causes them to become swollen or edematous. They get kind of big and boggy and they don't work as well. So it can cause a lot of the same symptoms, including double vision and dry eye and ocular discomfort and all of those other things. So fortunately, even with the overlap of the conditions, there's some overlap in treatment, but there are some important differences. And so we want to understand what of this is coming from myasthenia and what might be coming from another concomitant autoimmune condition. So again, another slide that you've seen earlier today in different forms, but just to again review why the symptoms in myasthenia gravis occur. So over here on this left side of the slide, you see a normal nerve, a presynaptic membrane here, packets of neurotransmitter acetylcholine diffusing across the cleft between the nerve and the muscle, and then binding on the muscle membrane to these acetylcholine receptors. In the case of myasthenia gravis, as has been pointed out earlier today, the nerve works fine. It releases these packets of acetylcholine, but these green antibodies bind the receptor so that the neurotransmitter cannot bind to the postsynaptic membrane and send that message through to the muscle to tell it what to do. A couple of other things, though, that I want to point out. about what happens in this pathophysiology is that on the postsynaptic membrane, because of the effect of these antibodies, the muscle membrane becomes more flat, it becomes less convoluted over time, and so that means there's less surface area for the neurotransmitter to bind. And there was also an excellent question earlier about downregulation or a loss of those binding sites over time in the course of the disease. So why this is important is if you think about the muscles that move your eyes around, obviously a very complex neurologic process, but the muscles themselves are pretty small. So in contrast to a larger skeletal muscle somewhere else in the body, if you start to lose receptors and start to lose surface area on the postsynaptic membrane, the symptoms can very quickly become fairly prominent and certainly pretty disconcerting in terms of day-to-day function. So it helps me to kind of conceptualize this in terms of a simple analogy. So what is it that we're really trying to talk about? And so sports analogies work pretty well for myasthenia. This happens to be a soccer analogy, just because my family spends an awful lot of time on the soccer field these days. But football, hockey, any other sport will work. So the general idea is that you have a nerve, and the nerve works fine, it's well trained, it's big, it's strong, it knows what it's supposed to do. And what it's trying to do is send a neurotransmitter, in this case the ball, acetylcholine, down the field to the muscle so that it can do what the muscle is supposed to do, and that is score a goal. But the problem with myasthenia is that the defenders are the stronger team. And so it's those antibodies that are blocking the signal from getting where it's supposed to go that causes the symptoms. And then when we think about treatment, we basically have two main categories. Pyridostigmine or mestinon, which is designed to just make it so there's more balls, so the defenders have a harder time blocking the signal. Or we can use immunomodulatory therapies like steroids or some of the other things that Dr. Sachdev talked about earlier today to block the antibodies. So that's basically how we think about therapeutics in myasthenia gravis, to try to either overcome that blockade by having more neurotransmitter around, or to try to take the defenders out of the picture so that the neurotransmitter can get where it's supposed to go. So why are the eyes either the first or sometimes the only symptoms associated with myasthenia gravis? Well, the first is that mild weakness can easily result in symptoms. There is an extraordinarily complex neurologic system that's responsible for moving your eyes in a coordinated fashion and keeping them pointed in the same direction. So obviously we have two eyes, but our brain sees one picture. And there's a very complex mechanism to keep our eyes coordinated and focused in the same direction. And our brain is very intolerant of that system not working properly. So if you have a little bit of a drift of one eye relative to the other in any direction, it's very disconcerting. And so the brain can perceive that in mild form as either blurred vision or unclear vision. Or it doesn't take much for the eyes to get so far out of alignment that your brain sees two different pictures, and that's the experience of what we call double vision. The other is that our eyes have a very high degree of metabolic activity. We've talked about how myasthenia gravis is characterized by fatigue over time. So if you think about it, all of us have been sitting in this room most of the day, not really using our other muscles, but we've been moving our eyes around all day long. And so even with relatively sedentary activity, the muscles around the eyes are very active, and so are very prone to becoming fatigued. We think that there's something about the structure of the extraocular muscles that lend themselves to be more susceptible to blockade. So we talked about a relatively small surface area, so it doesn't take a lot of antibodies to block the signal from getting to the muscle to make the muscles do what they need to do. And we think that there may be some specific autoantigens that precipitate or maybe even enhance the autoimmune effect around the eye. So as we start to think about newer treatments for myasthenia gravis that function at a more molecular level, there may be some interesting findings that relate to purely ocular myasthenia gravis as well. So this is just a cartoon that shows the nerves and the muscles in the eye, and I show this to you for a couple of reasons. The first is to understand, again, that this is a very complex mechanism that involves a lot of very discrete and very delicate neuroanatomy. So the signal that moves the eyes around starts here in the brain stem at the base of the brain, and then the nerves have to travel from the brain stem, in some cases a pretty long distance, to get all the way up into the eye to affect the muscles that move the eyes around. Why this is important, particularly for the non-neurologist or for practitioners who aren't thinking about myasthenia gravis, is that when we're trained to try to identify why someone is having double vision or why one of these muscles isn't working properly, the first thing that we want to do is what we call localize. So we think about the pattern of how the eyes are moving, which muscles aren't working properly, where the patient experiences double vision the most, whether it's to the right or to the left or looking up or looking down. And so they're thinking about a lot of this complex anatomy to try to figure that out. And frankly, most people who aren't crazy enough to be neuro-ophthalmologists aren't all that interested in this anyway. And so they don't really like to think about this. They see a patient come into the emergency department or to the primary care office with double vision, and they say, I just need to get this to someone who can sort it out. So they're not geared in thinking in these terms. The other thing is that as all of us know, there is no clear, consistent pattern with myasthenia gravis. So if you're looking at this and trying to say which nerve is involved, is this in the brainstem, is it somewhere else in the neck, you're just going to not really be able to think it through very well. And so what we really want to focus on, again, are those very discrete areas way out towards the eye where the nerve and the muscle come together. And that's where the pathophysiology of myasthenia in the eye happens. So again, just another schematic to try to help characterize the complexity of trying to figure out eye movements. So there are 3 sets of nerves that move the eyes. They come from the brainstem. They're called cranial nerve 3, 4, and 6. And they influence 6 muscles around each eye, and they all have a very specific role to play. But again, in myasthenia, it doesn't follow any particular pattern. So from time to time, or even at the same time, the double vision is not going to be easily identifiable as being one of these nerves or one of these muscles, because it generally affects different nerves at different times and in different ways. So if we see a patient who is reporting double vision, like this patient here, as she's looking straight ahead, you can kind of get a sense that her eyes aren't all that well aligned. The left eye here is kind of pointed straight ahead. The right eye looks like it's deviated out just a little bit, and so this is a patient who might be describing subtle double vision. But when we ask her to move into different directions of gaze, so if we ask her, for example, to look to the left, we can see that her left eye moves over just fine, but this right eye doesn't quite make it in towards the nose, so her double vision is worse when she looks to the left. When we ask her to look up, we get a completely different pattern. So we can see that her right eye looks up just fine, to the extent that you can't even see it anymore under her lid, which, by the way, is a little bit droopy. But the left eye gets hung up. It's not able to look up all the way. So different patterns, different nerves and muscles that can be implicated unless you're thinking about the variable pattern of myasthenia gravis. One other thing that I'll point out here as well is I've shown you an example just to kind of highlight the fact that this pattern of ocular misalignment can be quite variable. But this is an extreme example, and many of my patients will say during the times that they're experiencing double vision, they feel like anybody looking at them must think their eyes are completely misaligned, that they must look very abnormal. And the reality is that it doesn't take much to experience double vision. And so most of my patients with myasthenia, even when they're very symptomatic from double vision, their eyes don't really look to the outside observer all that different. And so I always encourage them and reassure them that from the outside, you don't look a lot different, even though you're experiencing this pretty significant double vision. So what are the eye symptoms that we know are related to myasthenia? So one of them that I see quite commonly is frequent visits to the eye doctor. Remember, we talked about how ocular misalignment doesn't have to be overt double vision. If the eyes are just a little bit misaligned, things are going to look a little bit blurry. And so a common concern of patients with myasthenia gravis is that their glasses just aren't right. So they'll go to the doctor, they'll get a new pair of eyeglasses, and those glasses won't work either. And that's for 2 reasons. The first is that, again, myasthenia gravis is incredibly variable, so sometimes you'll be symptomatic and sometimes you won't. The other is that when you go to the eye doctor, what's the first thing that they do to test your vision? They cover one eye, right? So you are eliminating, for the purpose of the eye exam, the contribution of your eyes not being pointed in the same direction. So from the eye doctor's perspective, your vision is perfect. When you're looking with your right eye, you're 20/20. When you're looking with the left eye, you're 20/20. But they fail to kind of put together the fact that when you're looking with both eyes, that's when things don't look right. And so that's a scenario that I encounter commonly. Of course, droopy eyelids, or what we call ptosis, is fairly common. And that also is variable. So many of my patients will have either one eye affected or both eyes affected. Sometimes it'll be continuous throughout the day, sometimes it'll only be towards the end of the day. So again, that variable pattern and the fact that it's very hard to localize to one particular part of the nervous system often discourages people from making the correct diagnosis. And again, symptoms worsen with fatigue. And so if we think about patients with ocular myasthenia gravis who are situationally symptomatic, so if they're in a situation where they are constantly looking up, for example, if you think about going to the movies, if you sit in the front row and you have to keep your eyes up to keep the screen in focus, you're going to become symptomatic sooner just because of that situational fatiguing component of ocular myasthenia. So how do we treat these symptoms? So just like with generalized myasthenia gravis, we start with pyridostigmine or Mestinon. And this is, I think, universally the initial treatment that we try. One of the things that I always tell my patients who have ocular myasthenia is that we're going to start you on this medication at this dose. It may work, and if it does, that's fantastic, but it probably won't, because the symptoms and the treatment of the symptoms is an incredibly individualized process. And so it's very frequent along the early stages of treatment that we are in pretty frequent communication to try to figure out how we need to adjust the dose to get better control. Do you need the same dosage spaced a little bit more frequently during the day, or do you need a larger dose that's spread out more throughout the day to try to get good control of your symptoms? The next step in therapy is oral prednisone or steroids. And so we generally think about moving to steroids if the Mestinon is ineffective in controlling the symptoms after you've adjusted the dose and given it an adequate trial to see whether or not it's effective. But I always mention to my patients with ocular myasthenia gravis, even when I first meet them, that Mestinon, for whatever reason, doesn't seem to work very well for double vision. So it may work really well for your eyelid, it may work for double vision, but it's not surprising if Mestinon is not all that effective. And so we generally, in our ocular myasthenic patients, will move to steroids relatively early because the double vision is so disabling and because we know that Mestinon may be pretty ineffective. And then the next stage, as you've heard about earlier today, is immunomodulatory therapy. So these are for patients with symptoms that are refractory to either Mestinon or to steroids after an adequate dose and a fairly reasonable duration. But we also think about moving to immunomodulatory therapy when there are significant steroid side effects. And believe me, for someone who uses a lot of steroids in my practice, I am very, very keen on using the lowest effective dose for the shortest possible period of time to control symptoms, because we all know the side effects of long-term steroid use. We also find that in patients with ocular myasthenia, sometimes tapering the steroid dose can be pretty tough. So if you do really, really well on 10 or 15 milligrams of prednisone every day, we start to taper people down and it just doesn't seem to work all that well. And so that's another indication to think about immunomodulatory therapy. And as Dr. Sachdev shared with you earlier this morning, there are a lot of new developments around immunomodulatory therapy for myasthenia gravis. And I think we're all very hopeful about how effective those medications will be. So how do we treat double vision? So obviously, if it's mild and if it's intermittent, you might just be able to ignore it or to adapt. I mean, some patients can learn to tilt their head or turn their head a certain way or just avoid certain activities if the diplopia is not very frequent or if it's not particularly disabling. Of course, we know that we can mechanically just close one eye or cover one eye, and that will get rid of the double vision as well, because remember, it comes from the fact that the two eyes are not aligned, so if you eliminate one of the competing images, things should go back to normal. Now, I will say that this is not often a satisfactory treatment for most of my patients long term. But again, if you're only symptomatic in certain situations or at certain times, and it doesn't really seem to be worth changing your medication therapy, this is something that many of my patients will find to be helpful. So if they like to read before bed, and when they lay down and they have their book on their lap and they're trying to read, that's the only time they have double vision. Sometimes they'll just cover an eye or wear an eye patch just for that period of time, and they get along just fine with other activities. Again, medications are very helpful, as we've talked about, so Mestinon or sometimes steroids, which are often much more effective. For ocular myasthenia, there are a few things that many practitioners will use to try to treat double vision that really don't help all that much. So eye exercises or so-called vision therapy often are ineffective, obviously again because of that fatigable component. So the more that you move your eyes around, the weaker they're going to get, and so that tends to be counterproductive. Prism lenses are very commonly used by optometrists and ophthalmologists to treat double vision, and if you're not familiar, this is just a special lens that they'll put over one or both lenses to compensate for the fact that the eyes aren't pointed in the same direction. For some of my patients with ocular myasthenia, it can help, but obviously a lens is not smart enough to alter its orientation based on what direction you're looking or what time of day it is or what type of activity you're doing. And so prism lenses can compensate for one pattern of ocular misalignment, but not for all of the others that are common and variable in myasthenia gravis. And so prism lenses are often not all that effective. Although it does work really well for our kids. So this is a child with a congenital esotropia. You put him in a prism lens and he's very, very happy. Our myasthenia patients don't tend to fare as well. And eye muscle surgery for the same reason. Because if we correct an ocular misalignment that is a certain orientation and a certain amount of degrees today, if you're a myasthenia patient, it's probably going to change tomorrow or certainly over time, and so we don't want to do anything permanent that it takes another surgery to reverse. So what about eye symptoms that may be related to myasthenia gravis? And we talked about how if you have ocular misalignment that's very subtle, it may not appear as double vision, it might just look like blurry vision. And so this is a simple test that I teach my patients to do. So if you think about patients like this, this individual can have myasthenia-related double vision because it's possible for his two eyes to become misaligned. But his partner here can never have myasthenia-related double vision, or in fact any neurologically mediated double vision, because he's only viewing with one eye. So if you cover one eye and your blurry vision gets better, then it may be related to a subtle ocular misalignment related to myasthenia. If you cover one eye and your vision is still blurry, then it's not myasthenia related. And so you can explore other possibilities for what might be causing your blur. Eye strain and fatigue is common among patients with ocular myasthenia. Again, if you have a subtle misalignment that is only manifest with certain activities, for example, reading or working on the computer for a long period of time, that may be related to myasthenia. And again, a good way to sort that out is just to cover one eye and see if it gets better. And if it does, then it's probably not myasthenia related. And then dry eye, which is epidemic in our part of the world, in Michigan, based on the fact that we go from a warm climate in the summer to a cold climate in the winter with lots of forest air heat and lots of pollens and all the other things that we live with. Dry eye is incredibly common. And so it may be related to myasthenia, or it may just be related to the fact that you live in Michigan and that you're prone to the same situations that contribute to dry eye in all of us. So I just wanted to show you a picture of what dry eye looks like under the microscope. So this is a patient who has had fluorescein, which is a vegetable dye that we instill into the front of the eye to look at the cornea. And all those little green dots, all those little green speckles are indicative of an inadequate tear film on the surface of the eye. So if you think about driving down the road with a windshield that looks like that, imagine what it's like if that's what you're looking through all day long with every activity. And again, it's incredibly common and it's very easy to treat. And the reason why we see it in myasthenia gravis has to do with the fact that the eyelids are often involved. The way that we refresh our tear film, the way that we keep our tear film moist is by blinking. And if your lids are not working to the extent that you're generating adequate blinks, dry eye is a common manifestation.
Is that floaters?
No, these are not floaters. Floaters are actually inside the eye. So the eye is filled with a substance called vitreous. It's kind of like the consistency of an uncooked egg white. And so every now and then, a little bubble or a little piece of that vitreous will kind of float around in the middle part of the eye, and when it drifts in front of your retina, that's what you perceive as a floater. So these will be, won't move around in the way that a floater does. It'll just look like really blurry, fuzzy vision. Exactly right. Yeah, this just looks much more amorphous and much less distinct. But it also contributes not only to eye strain, but also redness and pain and a lot of eye watering and just that kind of uncomfortable feeling that you get when you've been using your eyes too much. So again, maybe related to myasthenia on the basis of ptosis, but maybe completely unrelated, but something that's very manageable. Yes?
Are we saying that dry eye could mimic the symptoms of slightly misaligned?
Yes, absolutely. So that's an excellent point. But again, that misalignment will still be there if you cover one eye, if it's due to dry eye. So this can very easily look like double vision. Yes?
Could you repeat the question?
Oh, sorry. So the question was, can dry eye mimic a subtle ocular misalignment? And the answer is yes, but the way to tell is by just covering one eye and seeing if it's still there. So if you feel like you're seeing double when you're looking at your computer screen, and you cover one eye and you still see double, it's much more likely to be something simple like dry eye than double vision related to myasthenia. And so what about eye symptoms that aren't related to myasthenia? And I love the opportunity when I'm referred a patient with newly dosed myasthenia to tell them that this is not a condition that will make them blind. The symptoms that are related to vision with myasthenia gravis are generally pretty manageable and not something that is sight-threatening. And that's usually very reassuring for patients to hear that. So if your myasthenia is well controlled, but you still feel like you're not seeing well, again, common conditions are common. So maybe you do need an update of your glasses. There are other things that affect vision that are not myasthenia related. Again, that idea that sometimes if you have a diagnosis, everything falls under that umbrella is not true, particularly with things that are complex and complicated like vision. So thinking about cataracts, glaucoma, macular degeneration, the whole host of other eye things that can crop up over time, make sure that when you're seeing your eye doctor or when you're seeing your neurologist or seeing your primary care provider, you let them know that this is probably not something that seems myasthenia related, and we need to make sure that we're looking for other things. So just to kind of wrap up, when we're talking about myasthenia gravis and its effect on vision, symptoms are very common, they're very individual, and they're incredibly variable. So keep in mind that with symptoms that are kind of waxing and waning and coming and going and not fitting any particular pattern, it may be difficult for your eye doctor or your neurologist or your primary care physician to really pin down where they're coming from. So remember to just advocate on your behalf and on your family's behalf to look a little bit deeper and try to find if there's something else going on.